The next topic that we are going to discuss will be hyperkalemia. So basically, hyperkalemia means increased potassium levels, and many questions have been asked in certain postgraduate exams regarding this specific topic. Before you know about hyperkalemia, you should know when you will label a patient as having this specific pathology. Hyperkalemia is labeled when a patient's potassium is greater than 6 micromole millimole per liter. This is the range above which the patient will be labeled as hyperkalemic. What are the causes of hyperkalemia? You should know the causes, since ultimately this is the thing that you need to treat in order to get potassium levels back to normal. Number one is renal failure. Renal failure leads to increased potassium levels. It can be due to hypoxic ischemic encephalopathy, sepsis, hypotension that will lead to ultimately decreased renal perfusion and renal failure, and any structural abnormalities in the urogenital system that can lead to renal failure. Other causes of hyperkalemia can include cell injury. Cell injury basically involves destruction of the cell membrane that leads to increased expulsion or release of the potassium that was initially inside the cells. क्योंकि for example, in intraventricular hemorrhage there is obviously increased hemolysis. In any condition in which there is hemolysis, it will lead to hyperkalemia. And other example that is a famous one is rhabdomyolysis. An other basic cause of hyperkalemia may include increased potassium added to the maintenance fluids, or the fluids that are basically being infused to the patient. Endocrine abnormalities like congenital adrenal hyperplasia can lead to hyperkalemia. Other than that, there are also many other causes that includes abnormalities of the pH, that includes the usage of drugs, that includes the usage of or consumption of exogenous potassium. But these are the 4 things that you need to keep in mind just for the sake of management. Now, what are the signs and symptoms of hyperkalemia? You should know that in hyperkalemia, ECG changes are the main tipping point that will guide for the diagnosis. In ECG, the first sign that you will notice will be tall, tented, or peaked T waves. Tall tented T waves. The second thing that you will notice will be increased PR interval that will ultimately signify or indicate bradycardia. The third thing that you may encounter when potassium levels are further increased will be widened QRS complex, and the QRS complex will be wide to such an extent that the QRS may merge with T waves in the ECG, and it will be called as a sine wave. And the last thing, but that is not a definite one, there may be absent P waves. This slide, the things that I have written are very important, and these have been asked multiple times in different MCQs. Tall tinted T waves will be the first sign. Later on, if you increase potassium more, there will be increased PR interval that will signify bradycardia. Then further increment will lead to widened QRS complex such that it may merge with T waves and produce sine waves. These are very important. Now, the next thing that you need to know is how to treat hyperkalemia, because hyperkalemia is ultimately changing your ECG and causing arrhythmias. So, to treat hyperkalemia, there are two rules or laws. The first thing is that you need to ensure that the heart is stabilized. So that arrhythmias can be prevented. And the second thing that you need to ensure is you need to remove potassium from the body. These are the laws or the basics that you need to know. Now, there are some prerequisites or the things you should know while managing a patient with hyperkalemia. You should attach a cardiac monitor promptly. You should check potassium levels 6 hourly. But in case if the hyperkalemia is secondary to renal failure, then the levels should be checked 1 hourly. You should monitor the urine output and treat the cause. These are the basics of hyperkalemia management. These two laws that I wrote and the monitoring that you need to understand and follow during the management of hyperkalemia. Attach a cardiac monitor, check potassium level 6 hourly, monitor the urine output and treat the cause. Now the problem arises that in different setups, different types of management is being practiced. But according to the guidelines, this management needs to be followed, that I am writing right here. If the potassium is more than 6 and the patient has a normal ECG, then the management would be different. If the potassium is more than 7 but still the ECG is normal, the management would be different. If the potassium is more than 7.5 and there are ECG abnormalities, then the management that is to be followed is a bit different. Now, if a patient has a hyperkalemia of more than 6 and less than 7 and ECG is normal, then you just need to ensure that you stop potassium in IV fluids, stop oral potassium, stop any drugs that are causing hyperkalemia, like potassium sparing diuretics. So first you need to ensure that potassium is stopped from increasing in the blood. Then you need to reconfirm the results, reconfirm the labs, send the labs again. And the third thing is ECG monitoring, because if ECG shows signs of hyperkalemia, then your management will definitely shift to this part. Clear? Now, if a patient has hyperkalemia of more than 7 and a normal ECG, what you should do? You will give 3 things. What are these 3 things? Salbutamol, furosemide or the loop diuretics, and insulin. Once I am done with this management, I will tell the mechanism of action of each of these. Now, salbutamol, I will also write the doses so that it is a practical lecture for you guys. Salbutamol needs to be given, can be given via inhaled route, or it can be given IV at 4 microgram per kg in 10% dextrose water. And the dose can be repeated if needed. Salbutamol, furosemide. Furosemide is a loop diuretic. The dose is 1 milligram per kg. Everybody knows this dose. And insulin. For insulin, you need to remember that insulin needs to be given with glucose. And the dose is 0.5 units per kg. And what needs to be done is that glucose needs to be monitored, such that there should be monitoring of glucose for 2 hours total, and during the infusion 2 hours after the infusion, and during the infusion of insulin 2, the glucose should be monitored at or after every 15 minutes. So 15 minutes 15 every 15 minutes the glucose needs to be monitored. Now, if a patient has hyperkalemia of more than 7.5, or if there is presence of ECG abnormalities, then what you should do? The third thing is this. You should give the patient calcium gluconate. In most setups, this is the very first thing that you will do, but this is not a recommended thing. This should only be given if there are ECG abnormalities and the potassium levels are more than 7.5. The dose is 0.5 ml per kg and should be given in 5 to 10 minutes. And the second thing that you will give will be sodium bicarb. This bicarb will push potassium intracellularly. Okay, so these are the different management techniques in different situations. If potassium is more than 6 in normal ECG, you should just ensure that potassium is not being given to the patient, and labs should be reconfirmed and ECG monitoring should be done. If more than 7 in normal ECG, give salbutamol, furosemide and insulin with glucose. And if more than 7.5 and ECG abnormalities, calcium gluconate and sodium bicarb. Now, there are some other techniques as well to decrease the potassium levels. That includes exchange resins. Exchange resins can be oral or rectal. Oral exchange resin include petiromer, and rectal exchange resin includes kyaxylate. If you want to memorize the dose, then the kyaxylate is given at 500 mg per kg rectally with removal by colonic irrigation after 8 to 12 hours. Only if you want to memorize, but I don't think this is that much important. So this is the management of hyperkalemia. Now, just a quick overview of the mechanism of action. Calcium in calcium gluconate stabilizes heart membrane so that it is not prone to that much arrhythmia. Bicarb, insulin beta agonist, that is salbutamol, albuterol can also be used. These three push the potassium into the cells so that extracellular potassium is less and hyperkalemia is treated. And if they are asking what is the definitive treatment of hyperkalemia, the definitive treatment of hyperkalemia is dialysis. Dialysis. This is very important. Dialysis is the definitive treatment of hyperkalemia. And one more thing, if even by all these techniques hyperkalemia is not resolved, what you will do? Not practiced much, but can be used, and it is written in certain guidelines that you will proceed with exchange transfusion. So it is as simple as that. Firstly, you won't do anything, just ensure potassium stoppage, then you will give salbutamol, furosemide and insulin, and if ECG changes occur, then calcium gluconate, along with that bicarb. Other things include the coagulate and petri and dialysis, and ultimately the exchange transfusion.